I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips,
Hello, and welcome to the
Ira
November
Savetsky.
2018 edition of the PRS Monthly Journal Club podcast. I'm Nicole Phillips, resident ambassador from the Harvard Plastic Surgery Program, and I am joined for this podcast, as always, by my co-resident ambassadors, Francesco Egro from the University of Pittsburgh and Ira Savetsky from NYU. This month, we are honored to have Dr. Matthew Hanasono as our guest moderator. Dr. Hanasono is Professor and Reconstructive Microsurgery Fellowship Program Director in the Department of Plastic Surgery at the University of Texas MD Anderson Cancer Center. Dr. Hanasono, thank you so much for joining us today.
Thank you so much for having me, Nikki.
As always, our discussion begins with a brief reminder to our listeners that this article, along with every PRS Journal Club article, is available for free on the PRS website, where it is accompanied by selected article pairings and related video content. So please take a look at the section online as a great supplement to today's podcast. The article that I selected this month is titled The Feasibility Determination of Risky Severe Complications of Arterial Vasculature Regarding to the Filler Injection Sites at the Tear Trough. This is an anatomic cadaver study out of Thailand, with Benrita Jitaree as the first author and Dr. Tanva Tansadit as senior author. I will confess that my selection of this article was largely due to my own intense curiosity about the subject matter. With reports in the literature of blindness and other catastrophic events following periocular filler injections, I chose this article because I wanted to better understand the vascular anatomy of the tear trough and any related danger zones. Given the tremendous popularity and growth of non-surgical rejuvenation, I also thought this article was timely and relevant to current practitioners. As previously mentioned, this is an anatomic cadaver study designed to examine arterial locations relative to tear trough deformities and common injection sites, and thereby quantify the risks associated with these injection sites. The authors performed 30 hemifacial dissections from 15 cadavers, in which red latex injections of the arterial system had been completed. 3 tear trough injection sites were defined, and the local vasculature was then assessed in terms of horizontal and vertical distances from these 3 points. The 3 injection sites were described as lying along the tear trough depression line, which extends from the medial canthus and runs inferolaterally, parallel to the infraorbital rim. The first point, designated TT1, was determined to lie between the lateral limbus and the lateral canthus. The second point, TT2, was defined at the mid-pupil level, and TT3 was at 0.5 centimeters from the medial canthus. Careful layer-by-layer dissection was performed in order to determine which vascular branches were located in the area, at what level these branches were found, the diameter of the vessels found, and where these vessels were located in relation to the previously determined injection sites. As would be expected, variations in the periorbital vascular patterns were found between subjects, but certain consistencies were illuminated, which can help guide safe injection practices in the tear trough region. The main arterial supply to the tear trough region arose from branches of the facial artery, infraorbital artery, and ophthalmic artery. When examining the nearest arterial branch to the injection sites, no nearest arterial branch was found in the superolateral quadrant associated with TT1. The nearest arterial branch was found in the superolateral quadrant of TT2 and TT3 in only 1 out of 30 cases. The authors thus concluded that the superolateral quadrant is the safest region into which fillers should be placed when using these 3 injection sites. Further, the majority of the vessels in the tear trough region were found to lie within the supramuscular or submuscular planes. While no vessels were found in the subcutaneous plane, injection into this layer carries a high potential for contour abnormalities. Therefore, the authors agreed with previously published guidelines that suggest the supraperiosteal layer as the ideal injection plane in the tear trough region. The authors ultimately provide the following guidelines for safe injection of the tear trough. First, before beginning the injection, the practitioner should palpate and compress the inferior orbital rim and the inferior orbital fat pad. At the 3 predetermined injection sites, the needle should enter the skin at an oblique angle, approximately 30 to 45 degrees to the skin, aiming towards the superolateral quadrant. Care should be taken not to extend the needle's reach more than 5 millimeters in the horizontal and vertical axes, and filler should be deposited in the supraperiosteal plane and molded gently with the fingertips in order to achieve the desired effect. One of the limitations of the article highlighted by the authors is the fact that all of the cadaveric subjects were of Asian descent, and that there may be anatomic differences between patients of other ethnic backgrounds. Another limitation I was wondering about was the determination of anatomic injection landmarks on cadavers versus live patients. So Dr. Hanasono, this is a question I had for you. How accurate would you consider the placement of anatomic injection landmarks for a study like this? So if we're basing our injection landmarks on things like the lateral limbus and the canthus, I imagine that in a cadaver, these could maybe potentially look different than in a live patient, and that maybe dynamic forces in live patients could significantly affect these landmarks. So do we think that these results are reliable and translatable to a live patient from a cadaver study?
The paper itself has a tremendous amount of data in it, and I like to think of things kind of big picture. To me, the most important findings was the depth at which the blood vessels are. So it seemed to me, as you said, the safest layers would be the deep plane adjacent to the periosteum, although they didn't recommend it, the subcutaneous plane. And for subcutaneous plane, I'm thinking more of fat grafting injection rather than commercially available fillers. So to me, that was probably more important than the actual location, because as you said, the landmarks may or may not hold true. And the other thing is that what they showed was a fair amount of variability in what the nearest adjacent arteries were, which could be coming in from any number of different directions. So that was my feeling, my take-home point from this.
Absolutely. Thank you for that. Ira, what were your thoughts on this paper?
I thought this was a really interesting study. It really sheds light on something that is done quite frequently, and certainly every time I'm injecting in this area, I'm nervous. You're around the globe and you're worried about vasculature. So it's definitely an area that I think about a lot. In addition to what the authors discuss, certainly again, similar to what we discussed in the other article this month with fat grafting, is injection technique and the use of cannulas rather than a sharp needle are all ways to hopefully diminish the risk of having a disaster complication. So certainly as a resident, we're always thinking about worst case scenario, such as tissue necrosis, and even worse potentially is decreasing visual acuity. It's always good to think about how we would respond in those situations in the worst case scenario. Dr. Hanasono, what would be some of your tips? Number one, injection in this region, and how should we respond? Certainly hyaluronidase would be an initial step, but what are some advice you could give for the young aspiring plastic surgeons?
First thought that comes to my mind is that it really underscores the need for highly trained practitioners to be doing this kind of work. The kind of party line is that you want somebody who's appropriately trained and boarded and really knows the surgical anatomy of the region, I think, to be performing injectables in high-risk areas. Certainly, the informed consent process is important. I can't imagine, both on the surgeon standpoint and the patient standpoint, the emotional turmoil of doing something that should be relatively non-invasive and having a catastrophic complication like this. And I really do think the authors should be commended for their very systematic, very detailed work that I think is a reminder to all of us to try to avoid this complication. I don't know. I have no personal knowledge whether hyaluronidase or another treatment is worth trying. Certainly, emergency referral to an ophthalmologist would be reasonable in my mind.
Yeah, it's a really great point. I mean, obviously, we're well aware of many people out there doing injections, and you almost want to get on the streets and yell that this is not a joke, and really bad things can happen. We see it more than others because we're at national conferences and people are showing terrible things, and it is scary, and it does highlight the importance of being well trained and going to a board certified plastic surgeon and people that really understand the anatomy is really important. Francesco, what are some of your thoughts about this paper?
I thought it was an interesting study. Just like you guys, I commend the authors for attempting to address a key issue that can lead to very dire consequences. And I think it's great to have an idea of safe areas where to inject, but I think that the caliber of vessels and volume of soft tissue is certainly different in patients who are alive and have healthy soft tissue, just like Nikki said. So I think we should interpret these results with a pinch of salt, but it gives us a decent idea of how to be safer. And I think that's, in my opinion, the take-home message. Really, it's how can we try to make this procedure safer? I think that the gravity of the complications they are rare complications, but they can be very severe. And in fact, many surgeons will refuse to inject fillers in the tear trough due to the high risk, and the paper confirms there's more room for error. So, Ira, you already asked Dr. Hanasono what we should potentially do if these complications occur. My question to Dr. Hanasono is, should only more experienced physicians be performing these procedures? And what tips would you give to residents and newly graduates who want to approach injections in this area? Should they perhaps get more comfortable with other areas first, appreciate the planes and so on, and then maybe move on at a later stage to the tear trough?
Yeah, I totally agree with that. I think that one is to receive formal training. This article itself didn't really specify what type of filler, what diameter, fluidity, what type of cannula tip. It did warn in the discussion that small bore, sharp tip, needle type injectables are probably riskier than larger diameter, blunt tip cannulas. So I certainly think training is important. I agree with you. What you were alluding to is that there's probably a learning curve, and it's probably worthwhile to get comfortable in other areas before injecting in the tear trough area. And, and to my mind, I don't know if it's too extreme, but one might consider alternative solutions to addressing this area, whether they'd be a traditional open surgery versus perhaps considering autologous fat grafting, which in my mind at least, I think you'd be safer doing in the subcutaneous plane, given the results of this paper.
And I find very interesting that I was looking at the literature, and there are obviously various cases presented either as short case series or probably the largest case series from Park et al., who surveyed the Korean Retina Society. And, they reported a total of 44 cases. So definitely there are cases out there, but I don't know how frequently it is discussed. And we don't really have an incidence, for example, of blindness, which is the most dire complication here in the United States. I really hope that more research will be performed in this field.
Yeah, thanks, Francesco. I think that was one of the things when we were looking at, the articles that we pair with this article, for the Journal Club selections. It was interesting to see there's been a lot of reports about periocular complications from injections into the glabellar region and the nasal region, but actually in the tear trough region itself, a little bit underreported. So certainly an area for more research. All right, well, I think we've covered a lot of great points here. I think we should wrap up our discussion here for today. But I'd like to thank Dr. Hanasono and my co-resident ambassadors for this great conversation. I've learned a lot. I hope our listeners have as well. Before we sign off, I'd like to remind our listeners to tune in to the other two November 2018 PRS Journal Club podcasts. And if you like what you hear, please share us with your colleagues and rate us in the Apple iTunes Store. Be sure to visit our PRS Facebook page, and don't miss the monthly PRS Facebook Journal Club, where you can interact with each month's featured authors in real time. And thank you again, Dr. Hanasono, for joining us today.
Thank you. It was a pleasure to join you.